Harper aspired to create a shining model for other Obamacare exchanges, but instead it became its poster child of dysfunction. After spending more than $300 million in federal taxpayer dollars, Oregon pulled the plug last year and decided to default to the federal exchange. These words were written by Grace Marie Turner, March 31st of this year, a Forbes article. Welcome to People, Places, and Politics. I'm Patty Milne. My guest today is Mark Anderson. I'm going to introduce you, Mark, give a little of your background in just a moment. Let me share a few more words that Grace Marie Turner had to say in her Forbes article. The state is now embroiled in lawsuits with its primary vendor, Oracle, and current and former Oregon officials are the subject of congressional and other federal investigations. Depending upon the outcome of those investigations, Congress could demand that the state pay back the $300 million it spent on a project that numerous reports show was fraught with mismanagement and political maneuverings. Oh, you and I, Mark, have talked for the last couple, 3-4 years about what's happening in healthcare, the CCOs, and the Oregon Health Plan. And you have been yourself studying this and following it very closely. I'd like to introduce Mark. Mark is a business consultant, a political junkie, in your own words. Mark has an MBA from Willamette University, and he is finishing his doctorate in business administration at George Fox University. Mark is an award-winning writer and editor with 20 years experience. Also, you've done some programs. And most importantly, I know you as the host of iSpy Radio Show. So thank you, Mark, for being with me.
Yeah, thanks for having me.
Oh, this is the never-ending story.
It is. It's kind of the story that keeps right on giving, doesn't it?
It does. So you and I had the opportunity to visit in the last couple of days, kind of get reacquainted on what's happening to Oregon healthcare. And I know there are several points that you'd like us to touch on today. So go ahead and share with the audience what a couple of those issues are that really, really are important for people to know about what's happening in healthcare in Oregon.
Sure. Well, I think the biggest thing is that people need to understand that while the exchange for healthcare, Cover Oregon, would turn out to be such a colossal boondoggle that we decided it was so broken, $300 million couldn't fix it, that that's just really kind of the tip of the iceberg. That's how we pay for healthcare. But what's really happened is that the healthcare that you're paying for has been changed, and that is a story that has really been overlooked in so much of the healthcare coverage. I mean, the Cover Oregon really does tend to dominate the headlines and stuff because it's something that people, I think, can understand pretty easily. We've spent $300 million on a website that just doesn't work. People understand websites. They understand that, if I go on here, kind of like an Amazon marketplace, so to speak, then I can expect to pay certain amounts here and there, and people understand this. But what has happened with Oregon's healthcare is that, as you and I have discussed on iSpy Radio, is that it was really designed to shift to an Obamacare-like model despite whatever happened at the federal level. And this has been the radical transformation here of healthcare within Oregon that I think people really need to understand, is because it's kind of like you've gone onto a car lot. And you go to buy a Mercedes and you agree on a price, and then lo and behold, when you go out there to get in your new car, you've actually bought a 1973 Ford Gremlin. And so what you're buying has been changed, and I think that is the biggest thing that people need to understand.
What did people think they were buying? Maybe we could start there. What did they think they were buying, and what are they really buying?
That's a really good question, because as we have looked at some of what came out of that debate, there with the Democrats versus the Republicans, they all agreed somehow that, I shouldn't say all of them, there was the House overwhelmingly agreed. The Senate, however, saw better. But, and I mean the Senate Republicans and House Republicans. But what was really interesting was that when you went through some of the news articles, the Democrats all said, oh, this is exactly like Obamacare. Versus the Republicans said, oh, this is nothing like Obamacare. Well, where was it? Where's the distinction? And so what Oregon has done is they've shifted into a CCO model, Coordinated Care Organizations. And what this does is it gives a coordinated care organization. Think of it as like a corporation, and it gives you regional control within that. And what's interesting is that you had a lot of Republicans vote for this law, and specifically within the law, it waived antitrust laws. So in other words, it gave them an operating monopoly. And as anybody that runs a business knows, anytime you have a monopoly, costs are going to inevitably go up rather than down. And so that was the basis of, that's really the basis of our healthcare here in Oregon, is it shifted to that model. And that is actually part of Obamacare. Eventually, they do want to shift into those types of coordinated care organizations, although they call them an ACO. I believe it's Associated Care Organizations or something to that effect.
And actually, there was one article here I wanted to cite and give credit properly, but I don't want to shuffle through my papers. But the Oregon CCOs have been referred to as the ACOs on steroids.
Yes.
Just a much more, a bigger, broader program, and of course the effort here in Oregon just sort of kind of hit the streets running, and while other states are at different degrees of implementing CCOs and not implementing them, I guess full throttle comes to mind.
Yeah.
So again, but the point is, CCOs are very much a part, and it was intended by the Obama administration, whether they are called coordinated care organizations or by some other term. The point was that everyone, and ultimately everyone, not just those on Medicaid, receiving Medicaid, but here in Oregon, the intent was that every Oregonian would eventually be in the coordinated care organization.
Yes, and it says that very clearly in the legislation that was passed, even though the Republicans, when this first came out, they said this is not Obamacare and this does not touch everybody, this is just Medicaid and then eventually Medicare. In fact, a lot of them didn't even admit that second half, that eventually this would get into Medicare. But it said it very clearly within the legislation that this starts at Medicaid, then moves into Medicare, and then eventually into state workers, and then eventually for everybody.
Right. And then also it does include not only the Medicaid, but what's referred to as the CHIP, the Children's Health Insurance Plan. That, again, it's documented. It was in there initially along with the Medicaid people. So very, very intentional that these coordinated care organizations would be created, and very, very intentional for financial reasons that that these healthcare organizations would become involved in the coordinated care organizations.
Yeah. And that's an important point, because I think people may be thinking, okay, so I hear you that we're kind of shifting to a new model, but what does that mean?
Right.
And I can, you know, if you haven't really studied it, it's hard to understand what that means, and even when you've studied it, it's sometimes hard to explain. So basically what it means is the type of care that you're going to receive has changed. And what I mean by that is now, instead of just you visiting your doctor and going to say, well, you know, I'm not feeling well, I need to, you know, have a physical or whatever and have some tests run, that's going to shift. That's going to change away. Instead, you will be having a whole bevy of government bureaucrats between you and your doctor. Some of them who will decide, as I understand it, the eventual goal is they will decide whether or not you go to the doctor. And there will be health navigators that will help you decide, make better health choices. So you've got not just your doctor involved in your health care, but you've now have a whole litany of bureaucrats that will help you decide whether or not you should go to the doctor in the first place.
And a lot of these new employees, and we can talk later about the cost of all this, because so many people new to the medical field now, required by all of the Obamacare and the coordinated care organizations. But it's been referred to as gatekeepers, a gatekeeper between you and your doctor, because you have these individuals and they have minimal training of how to answer your questions and how to coordinate your care with your primary care physician and the whole bevy of experts. And then also a big piece of it was bringing in the mental health aspect, which I understand is really not financially carrying its own weight, if you will.
Well, that's not surprising, but the overall goal of the coordinated care organization is that, in theory, you would have a situation where somebody that's paid, say, I'm just going to use round numbers, $10 an hour, $15 an hour, is a lot less expensive for a patient that's considering needing care to go and spend a couple hours with them versus somebody that is a doctor that charges $100 or $200 an hour. And in theory, that's pretty good, except imagine any other business where you would do that. Imagine that you want to have your house built, and instead of paying the actual carpenter, you have somebody come in that charges $1 or $2 an hour and has never built a house ever. And so they have very minimal, as you say, minimal medical training. But the point again, is to have you see these people, and they can help you decide whether or not you really need to go see the doctor, and you can do that far less expensively than simply going to the doctor. And some of that is because they want to address the high cost of going to emergency rooms. And granted, there are a lot of people that use emergency services much like they would in a clinic. They call up 911, oh, I need to go to the doctor, I'm not feeling well. And that costs a lot of money. I mean, I know just from experience that my father-in-law was at a care facility, and they had to legitimately had to call the ambulance to come get him. He was having heart palpitations and whatnot, and so they had to come get him. Well, he was literally 2 blocks from the hospital, and it cost like $2,700.
Yeah.
And so it gets very expensive very quickly. And so these are good theories, but unfortunately the theories don't always work in reality.
And that's, I think, one of the overarching issues here. Again, you look at the numerous articles that have been written and people who are studying what's happened to this healthcare. Great ideas, in theory good, but it doesn't work in healthcare because ultimately you have the cost of care, you have the number of people you're taking care of, and you have the quality of care. And if any one of those elements is out of balance with the other two, something has to give. And what a lot of people need to be aware of also is Medicaid is rationed care. And it may not have started out intending to be, but as more and more people became enrolled, and we want to help low-income people have access to health care. It's wonderful if everyone can just go to the doctor when the need arises. But you at some point you have to determine, which in this case, of course, it's government. The government has to determine what procedure, what medication, what treatment is cost effective.
Yeah.
And I mention this because ultimately we're talking about people's lives, their very lives, and you no longer have the authority as a private individual, the patient, to say to your doctor, I want you to prescribe this treatment, and the doctor may even say it's what would help you the most, but you know what, it's just not on the list, it costs too much, and we're looking at how many people in this global budget have benefited from this particular treatment, and it just isn't going to be cost effective. And that is so key to all of this healthcare transformation, and very important as we catch up and study and you continue to look at some of the numbers that you've been looking at.
Well, there's a couple things there that you said that are really important. Is number one, is that you're right. Is that this is your health care that you're talking about. This is people's lives, but unfortunately, what the government is doing now through coordinated care organizations is they're reducing people to an expense. And I think the best description I ever heard of that was from Trevor Loudon. He's a blogger and international author from New Zealand, and he said that in a free market system, you're a customer. And in socialized medicine, which CCOs are, in a socialized system, you're a liability. And I think that is absolutely correct. You are, in fact, a liability to the government under this particular system. And one of the things they have decided to do to so-called, their attempts anyway, to lower the costs is to use what is called a global budget. And this is, in some of the write-ups you'll hear about this, it's called a global budget. And what this basically does is it takes all of the Medicaid dollars, dumps it into a single pot, and they then dole this out to the providers through capitation. And basically what this means, capitation means, is that this is how they expense something for how doctors are paid. And so in other words, they say, well, out of this group of 1,000, we'll say, you can expect to probably see most, maybe 20% of these on a regular basis, 10% of these on a very rare basis, and so on. And so we're going to divide the amount of money that you're going to get paid by the number of visits we think that you'll end up incurring, or by the number of people within that system. And so they have a formula that figures this all out, and it's very technical and whatnot. And so Oregon was paid this. They were actually given a huge grant. Actually, Kitzhaber went back to Washington D.C. to finagle some money out of the Obama administration, and through the miracle of politics, he was able to get $1.9 billion from the Obama administration. And I say that through the miracle of politics because for a very good reason, is because if you actually look at the numbers, and I did some digging this afternoon, knowing that I was going to be here, and if you look at the actual numbers, the numbers that I found for 2013 fiscal year for total Medicaid spending within Oregon was $5.1 billion. Wow. And so we asked for this extra money because we were going to redo all of our healthcare system and totally upend it, and we're going to find new ways to improve it. And so the agreement is that, okay, you can do that. We're going to give you this $1.9 billion, but the strings that were attached to that was you had to show actual savings. Well, so if you, and the savings that they said that they were going to save was 2%. And so when you hear that, you think, okay, well, that's 2% from $5.1 billion. That amounts to $102 million per year. And you think, well, that's pretty good, $102 million savings per year, except the problem is that that's not the 2% savings. You're not now suddenly spending, where you're subtracting that. Now instead of it's like $5.11 billion. Now all of a sudden you're just down to a nice even round number of $5 billion. So you've saved that money. That's not quite it. What the promise was is that we will save you money off the growth. And so instead of 5.4% growth, which is what they agreed to, they agreed that they would shave 2% off of that. So instead of a 5.4% growth, you've got a 3.4. And so, but the numbers don't add up, because when you take that off, when you actually add in the growth, your actual savings are about that $102 million. Well, okay, so in other words, and if you average that, if you assume that's an average for the 5 years, that means they have saved about $500 million. Well, through the miracle of politics, they're saving $500 million by spending $1.9 billion. So that'd be like me going to you and saying, hey, I've got this great financial investment for you. You can make $5,000, all it will cost you is $19,000.
Yeah. This goes back a little bit. I want you to, if you can, back up a bit and put that in layman's term. Perhaps using your car theory, people think they're buying a Cadillac and they're really getting a Gremlin, and it's through this miracle of government budgeting that it's considered a savings instead of an expenditure. And then not to mention people are not getting the health care that they really deserve or need.
Yeah.
So.
Well, on some of that, like for example, just to back up so that people understand that what they're saying is, if I said to you, I'm going to save you 2% on this expenditure of $100, we'll just use real small numbers. If I was to save you 2% on $100, you would instead be paying $98. Except what they're saying is, I'm going to save you money off of the growth. And so what they're saying is that this is going to grow by 5%, which would be $5. So instead of being $105 next year, it's only going to be $103. But again, to get that way, it's going to cost you $19.
Yeah.
So just so that people understand, that's where it's coming from. But in terms of, and then I forget the other half of your question there.
I was just for the audience to be able, in the layman's terms, so what does this mean? We really aren't saving any money. It's really costing us money.
That's correct, because the actual growth goes up every year.
Right.
We're not reducing actual costs, and I think that was where the lie lay, was that with what Republicans heard was, oh well, we're saving money every year. We're going to reduce our expenditure, and that's not it. We're reducing the amount of growth.
And by reducing the amount of growth, again, there are people not getting the service, but also going back to the rationing aspect of it, in order to keep the expenses down, the global budget under their budget parameters, you have to make adjustments somewhere.
Yeah.
So the growth wasn't quite as much, and I'm not sure why that growth wasn't there when in other conversations, We touched on this a bit at the beginning of the program, or maybe we were talking outside. So you have the Medicaid people. Then the desire here in Oregon is for every Oregonian, even everyone who lives in Oregon, not necessarily a resident of Oregon.
Yeah, I see where you're going
so,
with that.
So these numbers get really squishy, and the numbers, and you can play with numbers, really do not tell the story of why we're spending so much money, yet more people need to be brought in. They weren't actually brought in because the money wasn't really there to serve them.
Yeah, it's kind of an interesting philosophy when you think about it, because what they're really saying is that by adding more people to the system, we're going to save money, and yet we want to save money by stopping people from using the system.
Right.
So it's a real problem there in terms of their philosophies. They don't mesh, and in terms of the global budget, they really do have to start making some costs. Getting back to what we said earlier, which was that you're a liability now to the government, and so every time that you go to use the doctor for whatever reason, you're a liability. You're now costing the government money. You're costing your fellow neighbors money because their taxpayer dollars are paying for this. And so the problem then becomes is okay, so how do we cut costs? And unfortunately, that's what they're not really examining. I think they think they are, but they're not really. Number one, their first approach was wrong right from the get-go, is because they decided to put these monopolies into place. And monopolies, whenever you get that happening, you're always going to have costs go up, not down. And so instead of having the CCOs having operational monopoly, that means then that they can't have any competition coming in from outside, because this is a closed system. The CCOs are a closed system, and you can't have this competition that would normally drive down costs. And so in terms of patient care, that again, it becomes a rationed sense of care, because now if I want to go to the doctor twice in the year instead of just once, I'm driving up costs for everybody. And again, their idea is to essentially stop people from going to the doctors, because that will essentially save care or save the overall payments that are going out, because if you can stop people from needing the doctor so much, if they can do it through improved healthcare systems, such as you're taking better care of your health through better nutrition, not smoking, not drinking. And that's the other thing that I think people really need to understand, is once you give permission of your health to the government, they then have a responsibility to keep their costs low. And so what does that mean? What that really means, that when the government has the responsibility to keep your health care costs low, what you're really doing is you're giving them permission to take control over every aspect of your life. They can tell you to stop smoking. They can mandate that you have to lose so much weight. And I understand that I'm overweight right now. I've actually lost 20 pounds in the last 2 months. And
congratulations.
yeah, it feels good. But the problem is because my particular situation was such that I was behind the computer all the time. I knew that I needed to lose weight, just haven't taken the opportunity to do it. But it should be my choice, not the government coming in and saying you have to lose that weight. But because they have done some, and again, we were finding out all the times that a person's weight doesn't necessarily tie to their health. And same thing with now, I think the latest one is salt. As they found that, salt doesn't necessarily affect your health so much. But you've got all these government bureaucrats in there making the decisions for people's health care, rather than just people deciding whether or not they need to go to the doctor. And so it becomes very convoluted, and because you have now essentially given over control of your own self to the government, that's what gets really scary. And one of the things to me that was especially scary was that within the healthcare system that has been set up, is that they were really pushing mental health care.
Yes.
Which means that things like, and you can extrapolate this. I mean, we just saw it play out in Colorado and Indiana and all the rest. And regardless of what people think about the Religious Freedom Acts, the reality is you now have a government that can decide whether or not you are mentally healthy.
Yes.
And that gets really scary, because now all of a sudden you can say, you know what, you as a Catholic, and I think you're a Catholic, you as a Catholic, you're pretty intolerant. And so we're going to put you into some mental health care until that you understand that you being so intolerant and following your religious beliefs is actually a form of mental racism. And so we're going to make sure that you come around to the thinking of the rest of us.
And when you have a physician looking at all these aspects of your life and just these issues you're talking about, then having to decide how to spend that global budget. And they're saying, you know, Jane Q. Public has this mental illness, and we need to provide whatever treatment, but Jane also maybe has diabetes or something that is a drain on their global budget, and then they have to make decisions of exactly what they're going to treat.
Right, exactly right.
In fact, it's real scary, and it's these, pardon the expression, similar to the bean counters in the basement with the dark glasses saying,
and the green visor.
The green visor, the line is here. We treat these things because they're cost effective. We don't treat these things. And Jane Q. Public, you know, she's putting a real burden on our global budget.
Yeah.
And I'm certain that there may be people listening to our conversation saying, these two are nuts. Well, you have been doing a tremendous amount of research on this for the last several years.
And I can tell you from personal experience that that's already happening.
Yes.
And so you're not only being, not you as a patient are no longer a customer of that doctor. Instead, you're now a liability to the government, but in addition to that, you're now a statistical anomaly.
Right.
And I actually had this happen in my own life. I take my father-in-law in for a visit. He's blind and needs a lot of care. And so we had taken him to this doctor, the same clinic. New doctor had come in, and as part of that, they were kind of reviewing his files and whatnot. And so the physician's assistant was there, and they were asking him various questions about his surgeries. He's an old football player, and so he's gone through a number of surgeries, shoulder, knee, and whatnot. He's kind of the $500,000 bionic man instead of the $6 million one. But anyway, and I reminded him, oh, well, you had a prostate cancer or something like that, didn't you? He said, oh, that's right. Yeah, I forgot about that. I don't know. And so the PA, who was probably in her mid-20s, started to ask, she goes, oh, really? How old were you when that happened? And so we did some math, and we figured it was in his early 70s. And you know, now he's 92 actually, I think, if I remember right. But anyway, so she said, oh, that's interesting, because nowadays, if you were 70 and nowadays, if you had that, we wouldn't have elected for surgery. We would have just let you have that. And I said, well, really, why would they do that? And they said, well, because now what they find is that most men die of prostate cancer whether they know it or not. And
so I'm going to have to cut you short on here. We're running out of time, but I want the audience to really think about what Mark has just said. And I have my own stories to share of procedures. The doctor saying, oh, you don't need, it's been determined you don't need that anymore. Well, and they're looking at my age. We're going to have to cut this short. And I want you to come back, Mark, because I've not been following as closely the last few months all this healthcare stuff. You and I had a chance to visit, and there's so much. And the point of this conversation, and one very near in the future, is so much of the information that the general public is getting is not the information you really, really need to be getting. And so Mark and I will continue this conversation to make sure you have some more information that really will make a difference in your personal health. So thank you again for coming and talking this evening.
thank you for having me.